Assalamu alaikum. Today we'll talk about community-acquired pneumonia. The most important points we will talk about are the definition of a community-acquired pneumonia and how to identify high-risk patients and to determine and to select the antibacterial based on the risk of the patient. The diagnosis and treatments of adult with community-acquired pneumonia are based on the guidelines of the American Thoracic Society and the Infectious Disease Society of America. We'll talk about four cases. First case, the 30 years old male patient with no past medical history and 1 week ago complained of low-grade fever, sore throat and cough, minimal sputum production, and by examination there is diffuse wheezes. The vital sign was blood pressure was 120 over 80, respiratory rate 16, PaO2 90 millimeter mercury. On room air patient is oriented, TLC is 6,000, platelet at 250,000. The PUN is 15 milligram deciliter. Chest X-ray revealed the bilateral interstitial infiltrate. This is the case number one. Case number two, 15 years old male patient with productive cough, 2 days, high grade fever. Patient was recently admitted for MRSA cellulitis examination, found bronchial breathing in the right upper lung zone. The vital sign was where the blood pressure was 120 over 80, respiratory rate 32 per minute, PO2 is 50, patient is hypoxemic, patient is oriented, CLC is 4,000 and 4,045, 4,050, 400. Platelet is 150,000. PN is 40 milligram deciliter. And the chest X-ray revealed the right upper lobar consolidation. Case 3, 65 years old male patient, 3 days ago, complained of high-grade fever, productive cough with hemoptysis and erythematous rash. The patient has a chronic renal disease, so it has a comorbidities. The patient has a comorbidities. By examination, there's bronchial breathing, so the patient is complaining of the bronchial breathing. So we suspect to found the consolidation pneumonia and wheezes over the right lung. The patient was hypotensive, blood pressure 80 over rate 35, hypoxemic, PO2 is 60. Patient was confused due to chest infection, pneumonia, and the high grade common in geriatric patient might be misleading. The patient has a central affection, but it might be due to pneumonia, abdominal sepsis, UTI. Should be considered especially in geriatric patients. This TLC is 3,000. So, and chest X-ray revealed the right middle lobar cavity pneumonia. Case number 4, 70 years old patient complaining 4 days from high-grade fever, productive cough, generalized fatigue. Patient had a history of COPD with repeated hospital admission, so there is high risk of MRSA and Pseudomonas. Should be kept in mind during the taking a history from the patients or the relatives. By examination, there is diffuse wheezes and bilateral crepitation. This is the X-ray of the patient's blood pressure was 100 over 60, respiratory rate was 25, PO2 is 80, patient is oriented, TLC is 15,000, and PON is slightly high for 45 milligram deciliter, and chest X-ray revealed the multi-lobar infiltrate. So we have 4 cases with 4 different scenarios, but all cases are considered to have a community acquired pneumonia. So, what is the key points for managing these 4 patients? There is a big difference in the management of this patient, as we will discuss today. The community acquired pneumonia in any disease, we should know the diagnosis of the patients. We should know if the patient has a risk or not, patient at risk factors, and patient management. So the diagnosis, to diagnose pneumonia, There is symptoms of acute lower respiratory tract illness in the form of cough, increased sputum production, new or changed infiltrate on the chest X-ray. To diagnose pneumonia, we have the chest X-ray findings. At least one systemic feature like sweating, shivers, fevers. Patient not hospitalized or the long term have a long-term care facility for more than 14 days before onset to exclude the HAP or VAB pneumonia. So, in community acquired pneumonia, there is a different radiological find. The typical finding is a lobar consolidation, it's bacterial pneumonia. While we can find also a cavitary lesion, which is common in patient presented with MRSA or staph infection and fungal infection. And the interstitial pattern is the most common pattern in viral infection pneumonia. The most accused or microorganism or bacteria in the community acquired pneumonia is streptococcus gram positive organism, and for this reason, as we discussed before, why we didn't use ciprofloxacin and we should use fluoroquinolones like levofloxacin or moxifloxacin because it covers streptococcus pneumonia. Also, gram-negative influenza. For streptococcus, there is a prophylaxis vaccine, which is a pneumovax, which could be given for those patients with recurrent strep pneumonia, and gram-negative influenza, which is also one of the most common bacteria that lead to community acquired pneumonia with the H influenza vaccine, which could be given the prophylaxis, especially in in high risk patient with multiple comorbidities. The atypical pneumonia as mycoplasma or Legionella or chlamydia, the viruses as the respiratory syncytial virus, the influenza, para-influenza virus, the COVID-19 virus. One of the most serious microorganisms are the Staph aureus, MRSA, and Pseudomonas in patients with high risk of with MDR bacteria like Pseudomonas or Staph. The patient risk is very important. We have two risks for the patients, either risk of MDR, and according to this risk, we choose antimicrobial, and risk of severity, and according to this risk, we decide where to treat the patient, either at home, at ward, or in the ICU. So, patient and risk factor of MDR, we have risk of MRSA or risk of Pseudomonas. We know this the risk by knowing if the patient has a previous colonization, previous culture in the last 12 months with MRSA or Pseudomonas. The patient has a PACE score, which include the Pseudomonas aeruginosa, Enterobacteriaceae, and the Staphylococcus aureus. PACE score more than or equal 5, the high risk of MDR, and this risk includes the age of the patients, sex of the patient, previous antibiotic use during the previous 90 days, chronic respiratory disorder, COPD, or asthmatic patients, and chronic renal disease or patient on regular dialysis. At emergency departments, we might find the impairment of the conscious level or agitations, but fever or shivering not common in patients with MDR bacterial resistance. So the patient risk factor, we can use more than one risk factors, and each risk factors will classify where to treat the patients. The pneumonia severity, first is pneumonia severity index. The pneumonia severity index, we classify the patients. If the patient had a class score less than 50, or from 51 to 70, we can manage the patient as an outpatient, while patients with score from more than 71 or till 130 or more should be managed in the as the inpatients. But what is the pitfalls for this risk factors? PCR in the outpatient or inpatient, not inpatients in either ward or ICU. Okay, while the group index or group risk score, each criteria counts as a 1 point. Confusion, uremia, respiratory rates, blood pressure, age more than 65, and those patients, this score will classify the patients if he will be managed in the outpatients, inpatients, or the ICU according to the patient score, and the worst score is um, 4 or more. The American Society also the ETS criteria for pneumonia, community acquired pneumonia, classify the patient severe CAB or or minor CAB. The severe CAB, one major criteria which include the septic shock, respiratory failure require mechanical ventilation. So there is no debate as the patient will be admitted to the ICU with septic shock and need mechanical ventilation. Minor criteria include a lot of criteria. If we have 3 or more minor criteria, this patient should be managed in the ICU. Okay, respiratory rates, patient is tachypnic, hypoxic, there is lower infiltrates, confusion, uremia, leukopenia, thrombocytopenia, hypothermia, or hypotension. Okay, the the guideline recommend using a PCI over group to determine which treated as an outpatient or inpatients. Okay, so as we said that PSI classify the patients to out and inpatients, while group patients, inpatient, outpatient, or ICU patients. The American Society criteria divide patients into non-severe and severe CAP. So patient risk, if we discuss the first case, as we said, is 30 years old, male patients, diffuse wheezes, and there's bilateral infiltrate, no previous colonization. The PIS score is 0. So PSI is 1, group index is 0, and ATS is absent. So this patient has a low risk and could be managed as an outpatient. This is case number 1. Okay, case number 2, 55 years old patients, but patient has a history of MRSA, okay, and patients at the PSI 4, the group index is equivocal to, but ETS 3 minor criteria. So this patient should be managed in the ICU. So we have to check for just 3 scores and we take with the highest one. Group index indicates that the patient might not need ICU, but ATS, there is 3 minors to the patient in need for ICU. Patient number 3. This patient is has a no previous colonization and base score is 6. Okay, the a high risk of MDR, the PSI score is 5, and the group index is 5. ATSO has a major criteria. Patient is chugged, blood pressure is 80/50, so this patient should be admitted to the ICU. Okay, the patient number 4. It's assumed that this 70 years old patient and has a history of COPD and repeated hospital admission. Globally, at the first look, you think that this patient will be admitted in the ICU, but this patient has a no previous colonization. PIS score is 5. High risk of MDR, yes. PSI is 3. ATS has a 1 minor criteria. So this patient will be managed in the hospital admission. So the age is not always risk factors, might be the comorbidities more than the age or the acute illness the patient admitted by his acute illness to the hospital. How to manage those patients, managements either in the hospital or in the outpatient or ICU. In patients according to the disease severity and risk of MDR, while the outpatient, the presence of comorbidities and risk of MDR. Okay, there is a big difference in the management between both groups. So, in the inpatient managements, if we have patients has no previous colonization with MRSA or Pseudomonas in the previous year, and patients has no a previous hospitalization or IV antibiotic in the last 90 days. And this patient, there's no non-severe disease. So we can start with combined or monotherapy. Combined therapy, which is a beta-lactam, macrolides, or quinolones alone. If the patients in the right side of the chart, if the algorithm, if the patients had a no colonizations and they no previous admission or IV antibiotic on the last, but he's a severe disease, we should start with beta lactam plus macrolides or beta lactam plus fluoroquinolones. Beta lactam in the form of what? In the form of okay. Um, okay. So in these patients, we start with beta lactam macrolides in the non-severe disease and has no previous colonization. Beta lactam, which are the ceftriaxone. If this patient has um, if this patient has severe disease, we should start with only combinations. There is no monotherapy. Okay. If the patient has no previous colonizations, but he has previous hospitalization within the last 90 days, he is a non-severe disease, we will go for combined or monotherapy as the first one. Okay, combined or monotherapy, combined with beta-lactam, macrolides, or fluoroquinolone. So, if the patient has no previous colonization with MRSA or Pseudomonas, but the patient has previous hospitalization and IV antibiotic, okay, is and has a severe disease, he is admitted in the ICU, we should start with empirical cover for MRSA and plus or minus Pseudomonas from the start with a coverage of atypical pneumonia. So if the patient have a previous colonization, the left side of the chart, and or Pseudomonas in the previous year, we should ask for nasal MRSA, sputum culture, and blood culture. So we should give third generation cephalosporin, vancomycin, uh, and macrolides. And if there is high risk of MRSA, a high risk of Pseudomonas, there is no high risk of MRSA. Nasal swab was negative, so we will go for piperacillin, tazobactam, or cefepime plus macrolides. If the patient has pulse, we should give piperacillin, tazobactam, or cefepime plus vancomycin and macrolides. This is for the inpatients. And what about outpatients? Outpatients, if the patients have comorbidities or not. What are the comorbidities? Diabetes, chronic lung disease, alcoholism, as previous splenectomy, a heart or liver or renal end-stage diseases, malignancy. If the patient has comorbidities, we should go for amoxicillin clavulanate or any cephalosporins plus the azithromycin or vipramycin or quinolones alone. Okay. If the patient has no comorbidities, we should search for MDR. If there is no colonization but there is a high risk, we should go for the amoxicillin or plus azithromycin or doxycycline or fluoroquinolones. Okay, and if the patients has previous colonization with MRSA or Pseudomonas, we will cover MRSA and cover the empirical cover for both. And but if there is no colonization and there is no risk at all, and the patient has no comorbidities, we should go for only amoxicillin, like unison, okay, or any augmentin of with clavulanic acid, or vipramycin, doxycycline. But keep in mind that doxycycline has a loading dose of 200. The first dose then go for 100 every 100 milligram every 12 hour, and we should um, keep in mind in hepatic patients. Regarding the management, case one, as we said, this patient has no comorbidities, low MDR, so this patient we can give only doxycycline or amoxicillin. The second patient has a severe CAP, high risk of MRSA. We give piperacillin, tazobactam, plus vancomycin and macrolides or quinolones. The third case, severe CAP, we should cover with empirical, with high risk of MRSA and Pseudomonas. We should cover the by piperacillin, tazobactam, plus vanco, plus macrolides or quinolones. The patients number four, there is not severe CAP, so the patients we can go for beta lactam plus macrolides or quinolones alone, monotherapy for this patient. So, what is the optimal duration of antibiotic in CAP? Regarding the duration of antibiotic in CAP, if we are using azithromycin, we can go for only 3 days. Okay, the standard CAP pneumonia only 5 days. We can extend if the patient has a comorbidities for 7 days. Also, in the outpatients, in the inpatients, we standard cap for 7 days. The patient with suspected MRSA also for 7 days, but the patient with suspected Pseudomonas pneumonia, we have to extend the duration for 14 days. Thank you.